Hello for all the listeners and welcome to this session. My name is Juha and I come from a diagnostic company called ArcDia International. Uh, Thanks for the organizers to let me have this opportunity to speak in your national conference. I was given this title, How to Manage Influenza Season During COVID-19, Diagnostic Point of View. And I'm going further now. So I come from Finland. I live in Finland. I have a background in vitro diagnostic and virology in medical department of University of Turku. I have more than 10 years of experience in developing diagnostics and study infectious diseases. I have specialized in acute infections such as influenza, RSV, or norovirus. So I'm working with these Maripoc analyzers and Maripoc tests in test development and research. So the Maripoc analyzer is very easy and simple to use. When you have done the sample pretreatment, you just only add the sample tube inside the analyzer and the analyzer does everything automatically. It has a very sophisticated auto verification system which controls many things in the measurements and provides the results as okay if everything is okay. So the test system is detecting viral antigens or bacterial antigens, and it analyzes multiple analytes from one sample. So here is a test result report for Maripoc Respi test plus test. It has 11 pathogens and it includes this recently developed antigen detection test for SARS coronavirus 2. Here is an example how the results are shown, whether the analyte has been negative or positive, like in this case. The sample pretreatment for the Maripoc test is very simple. You cut the swab in the tube, you add sample buffer, and then you add barcode which identifies the tube, the patient for the analyzer. And then you vortex the sample before inserting the sample inside the analyzer. The hands-on time is less than 1 minute, very simple. The Maripoc assays are based on our own ArcDia 2-photon excitation assay technique. We have inside this kind of cartridges, we have the basic sandwich immunoassay on solid phase microparticles and fluorescently labeled antibodies. So we are detecting individual microparticles from each well. So there is one analyte per one well. So, and the fluorescence signal is detected with a highly sophisticated fluorescence optical reader. I found this one interesting paper from a Romanian influenza-like illnesses. So in this study, they wrote that from influenza-like illnesses with severe acute respiratory infection, 1/3 could be explained by influenza. So this raised me a question, whether 2 of the third these severe hospitalizations were due influenza-like illness, which was caused by other viruses or bacteria. So this was in a few years ago, but now we have, in addition, the SARS coronavirus 2 among us. So the case is at the moment that there is SARS coronavirus 2 circulating among the population, but the influenza season is coming, and influenza, RSV, they will be soon in the population too. So the case soon will be that we have multiple circulating viruses, all having symptoms of COVID-19, and they all should be tested for COVID-19. There are papers saying that the co-infections are more severe than individual infections. It's not always the case, but sometimes. So what could we do? The best option would be that we can prevent the mixing of all kinds of viruses by identifying the viruses and controlling these infections. So at the moment, diagnostics is done mainly for COVID-19, and this can cause that if only the SARS coronavirus 2s are detected, the other viruses will be circulating, and the more we are focusing on SARS, the more the other viruses will spread among population, and then more and more COVID-19 symptoms patients are there, and we have to test also those. So all the symptomatic should be tested for COVID, but also for influenza and preferably for other respiratory viruses as well. So one solution for the population of overlapping symptoms to how to handle the infections is to use multi-analyte antigen detection test. So you can identify the infection, and then you can control the infections. So you are all familiar with influenza and RSV diagnostic method, rapid tests, PCR, and so on. So let's focus on the COVID-19 diagnostic method. This is from USA. This is CDC guidance about rapid tests. So when the COVID emerged, PCR tests were rapidly developed all around the world. But now there are also rapid antigen tests available, and CDC concludes that these rapid antigen tests are particularly helpful. In the same guidance, they also refer the study by Larimore et al. That we should focus on frequency and availability of the testing and speed of reporting in outbreak control, rather than having the highest sensitivity with prolonged turnaround times. So this suggests that antigen testing may have benefits for early identification and controlling these outbreaks. Just recently, a few days ago, there was a discussion in New York Times about the sensitivity of PCR in discussion with the CDC recommendation, and there are virologists that conclude that the CT above 35 is too sensitive, and they would put a reasonable cutoff to CT 30 to CT 35, but they are also discussing that this clinical cutoff should be at 30 or even less. And they conclude that it is extremely difficult to culture or detect any live virus from specimens if the CT-PCR value is more than 33 cycles. So what we know about the infectivity of the persons, this is a conclusion again from CDC webpage. So based on viral culture, if you have mild to moderate disease, you can detect the live virus not more than 10 days. But in the case of critical illness or severe immunocompromised cases, you can likely detect the live virus up to 20 days. CDC also recognized that the SARS coronavirus 2 RNA in upper respiratory specimens can be detected up to 3 months after the illness onset. And for this reason, they are recommending that if a person have had a COVID infection earlier within 3 months, the PCR testing doesn't provide reliable information whether this is a COVID infection or not. So I will show you some studies where PCR has been compared to viral culture. Here you can see CT values and the percentages of the PCR positives that has been positive in viral culture. And so we can see that the higher the CT value is, the less you have viable virus in the specimen. So here you have 40 specimen positive in viral culture and 143 in PCR. So what all this means that you have a lot of RNA findings, but no viable virus. And this is that this CT lower than 20 suggests that you have very high viral load, but still you couldn't culture viable virus away from there. We have our own results with viral antigen detection, detecting the nucleocapsid protein of SARS coronavirus 2. And our results are showing very similar results when compared to PCR than the viral culture is compared to PCR. I'm not showing the results here because the specimens were in unknown samples transport media, so it's not optimal sample material. But the result suggests that the antigen detection correlates with viral culture. Here is just another paper showing that percentage of positive in culture, and when the CT value goes higher, the positivity in viral culture goes down. And here is a third paper providing quite the same information, that when you have a positive culture, those red dots, and negative culture, these squares, we can put a line between CT25 and CT30, and all on the left side of this line, these are culture positive, but on the right side, most likely are culture negative. And here they studied persons with typical symptoms, atypical symptoms, and pre-symptomatic and few asymptomatic cases. But again, it seems that when the CT goes higher, the less you will find viable viruses, although at some cases you can still culture the viable virus, although the CT is quite low. I mean high. So what we can say about these viral culture studies is that only very few samples with PCR-CT value higher than 25 contain viable virus. On the other hand, most of PCR samples with CT less than 25 contain viable virus. We can show this kind of conclusion about the coronavirus infections. Before the infection or exposed to the virus, you are not contagious, but just before the symptoms onset, you will be contagious. And when you are having the symptoms, you are most contagious and the viral level is high. After 14 days, you are most probably healed if it's not going very severe, if it's the normal case, and then you are again not contagious. There are tests like this PCR test, we call them exposure test. You may or you may have the disease, and here is how you can use the test at different levels. And then we have the antibody test, which tells whether you have the immunity or not. But it seems that the antigen detection, the nucleocapsid protein detection, provide similar results to culture whether you are contagious or not. One thing that is very important in antigen detection testing, but also in PCR testing, is the timing when you are taking the samples. So here is days since exposure, and here is probability for PCR negative, false negative result. So before onset of the symptoms, it's likely that PCR give negative result, but when the symptoms comes and you have days since exposure goes longer, you will get the PCR as positive, and in the symptomatic phase, it's most probable that you will get the positive PCR results. And when the days go after 14 days, it's again less probable that you will get positive in PCR or antigen detection test. So why a coronavirus antigen detection differs from RNA detection? Here's a viral life cycle. So when the virus enters a cell, it needs the spike proteins to attach the receptor on the cells, and the virus goes inside the well. Inside the well, viral replication happens. And after the viral replication has happened, the viruses are budding away from the cell. And all these viral components are needed for active virus. What we know about this coronavirus, the association with the nucleocapsid protein and the RNA. So we know that the nucleocapsid protein is essential for the coronavirus replication and transcription of the viral RNA. So the accumulation of N protein protects the coronavirus mRNA from degradation by the nonsense mediated decay pathway of eukaryotic cells. So the nucleoprotein has essential role in protecting the RNA from degradation. So the accumulation of N protein makes the replication 1,000 times faster and even more. So the N protein is crucial for the viral replication because the RNA is otherwise degraded. And we know that RNA are stable in double membrane vesicles and therefore can be detected long after the acute infection. So my conclusions are that rapid multivalent viral antigen detection can provide accurate diagnostics, right clinical diagnosis, and this into better prognosis. Time to results and easy to use, short hands-on time will give you the possibility for ad hoc sample analysis. So very easily you can take a sample, put it in the analyzer, and then you will have results within 2 hours. So thank you for your time, and I'm ready to answer any questions you might have.